Good morning, everyone, and thank you for giving me this opportunity to come and speak before you on this topic. We've heard about endometrioma and we've heard as to how tricky this thing is and whether it should be treated, whether it should not be treated. And as the other topics go, it's a matter of debate, and we will see what are. I will put certain points across. Devika will put her points across, and then it is up to the audience to take out a consensus and see as to what really should be done. So it's a still unsolved topic, is whether the endometriomas should be treated before in women undergoing IVF cycles. So should they be tackled or should they not be tackled? So as far as endometriomas and ovarian reserve go, we have these are the certain markers of ovarian reserve, as we all know: FSH, inhibin, 17-beta estradiol, FSH-LH ratio, anti-Mullerian hormone, and the antral follicle count. So as far as the results from IVF-ICSI in patients with endometriosis, they have been used to infer the influence of endometrioma per se on the ovarian function. And I would like to say at the outset, this population is biased, since the women who conceive spontaneously are not included in these studies. So the influence of endometriosis on results of IVF embryo transfer have been a topic of debate. And using a meta-analysis of methodologies, Bernhardt documented that odds ratio for pregnancy rate of 0.56% in patients with endometriosis, and the pregnancy rates in women who have severe endometriosis are lower than the rates with the mild disease. And most recent studies, they confirm these findings. So why are there conflicting results regarding that? Because IVF outcome could be managed, influenced not only by endometriosis, but by patient management, by different stimulation protocols used, by different laboratory procedures, and other factors intrinsic to each institution. So crucial roles should be attributed to control groups used to and to the selection criteria. Control group generally consists of women with tubal factor infertility, and the adequacy of this choice is debatable, considering that ovarian reserve and implantation may be reduced in these patients of tubal infertility also. Furthermore, it has been noted that in many centers, women with endometriosis and with a compromised ovarian reserve have been excluded. So there are 3 different clinical scenarios which should be considered. 1, patients with endometriomas who have not undergone surgery. Number 2, other patients who have been previously operated for endometriomas and who are disease-free at the time of IVF-ICSI. And the third group, patients who have been previously operated for endometriomas but have a recurrence at time of IVF-ICSI. So the findings from first 2 groups may be of particular interest because they allow to distinguish the effects related to the presence of endometriomas from those related to surgery. Further variables have to be considered are bilaterality of the endometriomas, dimension of the cysts, and the specific surgical technique used. Unfortunately, vast majority of studies have not taken these into consideration. The studies of IVF-ICSI in women with endometriosis, ovarian endometriosis, are limited by the fact in most cases only one gonad is involved. The limitation is important and poorly considered. Patients with single ovary do not generally have a reduced fertility potential to conceive through IVF treatment. In women with unilateral gonad, the contralateral gonad may be adequately compensated for the reduced function, and at a simple and reliable means to assess the influence of endometriosis or its surgical treatment on ovarian function is to monitor the response to ovarian stimulation during IVF-ICSI cycles in affected ovary and to use the contralateral gonad of the same patient as a control. This study design has been employed by 6 independent authors to investigate the effect of surgery. So the results are, in 3 of them, the numbers were reduced in cystectomized ovary, and some have not reported any difference, but they have included 12 IVF cycles. As previously mentioned, these authors only included patients treated with drainage and laser vaporization of internal layer of endometriomas. Responsiveness of cystectomized ovaries is reduced, may be of particular relevance in the women with bilateral endometriosis, whereas contralateral gonad, intact gonad, may adequately compensate for reduced function of affected gonad. Women with bilateral ovarian endometriosis may be at elevated risk of ovarian function impairment. Even if endometriotic cysts are monolateral, in majority of cases, both gonads are affected in 19 to 28% of cases. And moreover, in some cases, 2 gonads may be affected in subsequent periods. Surprisingly, no study has specifically investigated the outcome of IVF in women with bilateral ovarian disease. So how does endometrioma damage the ovarian reserve? It's important to note that at present there are no definitive data to clarify whether the damage is related to the surgery or presence of cyst. So what reduces the ovarian reserve, we do not know. It cannot be excluded that cyst per se damages the ovarian tissue. Using pathological sections of ovarian cortex surrounding ovarian endometriomas, Meneshi found that reduced number of follicles antecedent to surgery, suggesting disease per se may be detrimental to ovary. In a rabbit model, Kaplan showed that endometrial implants in ovaries decrease the number of ovulation points. No clinical studies have been set in unoperated women with monolateral endometriosis to compare follicular growth in affected and contralateral gonad. The prevalence of damage determined by endometrioma per se remains to be determined. A further unsolved task would be clarify whether this injury is permanent or transitory. Surgery, if it damages or it helps, apart from potential injury to the presence of the cyst per se, there are some evidence supporting the idea that surgery may affect the ovarian reserve. Now, it depends on how you've done the surgery. So you may remove a lot of tissue. So it's very important. One of the histological studies performed on pathological specimens, Musi et al. Observed that presence of healthy ovarian tissue adjacent to cyst wall in 14 out of 26 as compared to 1 out of 16 in 19 non-endometriotic benign cysts. So, a further mechanism potentially responsible for reduced ovarian reserve is represented by damage that may be inflicted to ovarian stroma and vascularization by both surgery and electrosurgical coagulation. Adverse changes have been reported due to stripping, but how you coagulate the bleeding vessels and you can use bipolar coagulation, and ovarian suture may be less damaging. So it depends as to how you've done the surgery also. So if you've done a good surgery, the damage will be not so good. So the question we come again is whether endometriomas should be treated prior to IVF. The meta-analysis by Bernhardt et al. Showed that chances of achieving pregnancy after IVF was significantly lower with patients with endometriosis as compared to tubal factor. There is decrease in fertilization rate, implantation rates, number of oocytes retrieved, and probability of pregnancy was reduced in women with severe endometriosis. The probability of pregnancy after IVF is decreased then treatment of endometriosis before IVF cycle might be associated with improved outcome. So you could use medical treatment, and there are different methods, which could be the medical treatment with drugs or with ultrasound. And GnRH, a prolonged treatment with GnRH analogs has been proposed, and patients were analyzed, diagnosed with various stages of endometriosis. It's not clear. The majority of retrospective studies concluded that reproductive outcome in women with endometriosis undergoing IVF is improved after prolonged down regulation with GnRH agonist before starting ovarian stimulation. This is also supported by 2 prospective studies by 1 randomized control trial, which compared prolonged down regulation to long agonist protocol. On the basis of current low quality evidence, it appears that such an intervention, that a long GnRH analog treatment before endometriosis, is beneficial. Danazol or gestrinone can also be used, and alternative treatment methods in women with endometriosis, medical treatment. A series of studies have investigated the opportunity to prescribe medical treatment, and these studies have been recently reviewed. Overall, there are evidence, though not robust, that use of prolonged GnRH agonist down regulation is beneficial in women with endometriosis. As far as ultrasound guided aspiration goes, ultrasound guided aspiration with or without concomitant local or systemic therapy is an alternative option and should be taken in consideration. Dicker et al. Documented a significant improvement in number of oocytes retrieved and embryos obtained. And in a retrospective studies, Suganima et al. Compared treatment of endometriosis before IVF either by laparotomy or laparoscopy to no treatment, and higher fertilization rate was observed in women treated with aspiration as compared to compared with surgery or who did not report any treatment. There have been contradictory reports, and 41 women were randomized for endometrioma aspiration at beginning of ovarian hyperstimulation, whereas 40 did not undergo aspiration. And fish and share potential benefits of adjuvant or local systemic medical treatment remains to be investigated. Number of oocytes retrieved and implantation and were similar. So you need more studies to compare this or get to a conclusion. Laparoscopy is a baseline investigation as well as for treatment, and what modality to use is to be seen, whether you do a stripping or you do a excision or you do ablation, and 2 randomized controlled comparing these 2 approaches documented a better pregnancy rate and lower rates of recurrence following laparoscopic ovarian cystectomy than after fenestration and coagulation. So the pregnancy rates after surgery have been reported to vary between 23 and 67% depending on type of laparoscopy, and it depends on the number of the characteristics of patients enrolled, length of follow-up, selection criteria, adhesion score, and surgical technique. And 40 to 50% of young patients with endometriomas may conceive after laparoscopic surgery. And only 1 study has specifically compared unoperated women with endometriomas to women who previously underwent surgery for endometriomas, and lower peak E2 levels and higher gonadotrophins requirement were documented in the operated patients. Conversely, number of oocytes retrieved and embryos obtained are same. Now, Canis failed to observe reduced ovarian response in patients who underwent laparoscopic excision of more than 3 centimeters diameter. To show reliably, however, the treatment of endometriomas in patients scheduled for IVF has a beneficial effect on reproductive outcome, a prospective randomized trial in patients with endometriomas are allocated to undergo removal of endometriomas need to be performed, and this data does not exist. Now, what are the arguments in favor of removing endometriomas prior to IVF? Endometriomas may interfere with ovarian stimulation, may impose difficulties during retrieval, and endometriomas have been considered responsible for producing substances that are toxic to maturing oocytes, affecting cleavage after fertilization, and endometriomas may themselves be responsible for compromising ovarian reserve by destroying ovarian tissue through their expansion. Without laparoscopic evaluation, the diagnosis of malignant transformation, approximately 1%, might be delayed, and endometriomas may be associated with risk of pelvic abscesses, or rupture or acute abdomen. Follicular fluid contamination with endometrium content and progression of endometriosis could happen. Exact impact has not been established. Risk of infection is real even if prophylactic antibiotics are given. And risk of missing an occult early stage malignancy is another rare but severe concern. And two largest available series concerning the risk of occult malignancy in endometriotic samples reported with a frequency of 0.8 to 0.9%.
Excuse me.
Just the last two slides. Difficulties during oocyte retrieval in women with endometrioma are a well-known problem, and affected ovary may be displaced in an uncomfortable position and perilous position. Follicles may grow beyond the endometrioma, thus requiring puncture of the cyst to allow aspiration of follicle content. Physicians may occasionally decide to avoid follicular aspiration in affected ovary if a sufficient number of oocytes have been retrieved in contralateral gonad. Accident contamination of follicular fluid with endometrioma content is not a rare occurrence during oocyte retrieval, and this aspect is of particular interest considering that it has been reported that endometriotic fluid may significantly affect the oocyte quality. So there have been these studies which are there to support the removal of endometriomas prior to IVF, and higher fertilization rate has been observed in patients who are treated with who have been treated before IVF. And so there are different things which affect the rates, which are the size of endometriomas, presence of adhesions, pain symptoms, age and duration, and cause of infertility. So you have to decide case to case basis as to who are the patients who will need treatment before IVF or who are the patients that you can do without treatment. Thank you so much.